Hi everyone, I'm Awi Madak. I'm the medical director with the Division of Public Health, and we're very happy to be partnering with the Medical Society of Delaware's Hot Topic CME program to bring you the Working for Equity series from the Health Equity Institute of Delaware. The hot topics are provided by the Medical Society as a means of providing clinicians with up-to-date information on cutting edge medical topics. So we're very happy today to have as our presenter, Dr. Erica Smith. Dr. Smith has been the interim state epidemiologist at the Delaware Division of Public Health since 2023. She came to DPH in 2019 as the deputy state epidemiologist. And in that role, she oversaw the COVID-19 epidemiology response during 2020 to 2022. Since COVID kind of died down a little bit since 2022, she has focused her time on training and mentorship for the approximately 35 epidemiologists within the Division of Public Health. Dr. Smith earned her PhD in epidemiology from Drexel University and her Master of Public Health in Epidemiology from Virginia Commonwealth University. And she also has a Bachelor of Science in Biology and Anthropology from the College of William and Mary. Before coming to DPH, she worked as an epidemiologist at the Pennsylvania Department of Health, the Virginia Department of Health, and the NIH Clinical Center. Please welcome Dr. Smith.
Great, thank you so much. So I'm super happy to be here, and I'd like to welcome you all. I'm going to share my screen. Can you all see my slides? Okay, great.
Yes, we can.
So today I'm going to be talking about social determinants of health as upstream risk factors for enteric illness. And this is work that I completed as part of my doctoral dissertation a few years ago. I know that Awi did a little background, but just a little introduction about me. So I earned my MPH from Virginia Commonwealth University. I was also a CSTE applied epidemiologist
and in every way that any major military operation.
Can people put their phone on mute or their mic on mute, please?
Thank you. So I was a CSTE applied epi fellow in Pennsylvania. And then after that, I was also a district epi covering a 13-county district of Pennsylvania that had 2.5 million residents. After that, I was a statewide foodborne and enteric epi in Pennsylvania. And then I left my job in PA to return back to school, and I earned my PhD in epi from Drexel. And as I said earlier, this is work for my dissertation, which I defended in 2019, just before I came to DPH. So I was the deputy state epi. I've been here since 2019, and as I mentioned, I was helping to head up our COVID response from 2020 to 2022. And then since then, I've really focused my time on supporting our EPIs and our informatics staff throughout the division. I really like to focus on training and mentorship, and also have helped with grants and other things like that. I do want to say that the views expressed in this presentation are my own, and they do not represent the official position of either Drexel University or Delaware Health and Social Services, and I also have no financial conflicts of interest to disclose. So with that, I'm going to start with the question. What is a healthy food? I want you to just take a minute and think of just an example of a healthy food that you would think of. Does the food that you thought of look more like a food from group 1 or a food from group 2? Group 1 are what we call energy-dense foods. They tend to be canned or processed, and they're often shelf-stable, and they often are relatively less expensive. We call them energy-dense because they tend to be higher in calories and lower in vitamins and nutrients. But eating too many of these foods may increase your risk for chronic conditions like diabetes, high blood pressure, and obesity. Group 2 are what we might call nutrient-dense foods. They're sold fresh, and depending on the food, can be eaten raw or cooked. They're often perishable and can tend to be more expensive compared with shelf-stable foods. We call them nutrient-dense because they tend to be lower in calories and higher in vitamins and nutrients. And eating more of these types of foods may lower your risk for chronic diseases. Now, I have another question. And if we were in a room together, I would say, I don't want anyone to raise their hand. I just want you to think to yourself. Have you ever had food poisoning? The chances are good that you have, because about 1 in 6 or 48 million people per year in the United States get sick from contaminated food. Foodborne illness or food poisoning can be caused by over 15 different possible pathogens, including bacteria, viruses, and parasites. Symptoms vary by pathogen, but often include nausea, vomiting, diarrhea, and abdominal pain. And the onset time can range anywhere from 30 minutes to 30 days, depending on the pathogen. But knowing the timing of what you ate and when you got sick can often help with diagnosis. Just a quick summary of bacterial illness in the United States. Salmonella, CDC reports that there are around 1.35 million illnesses per year, with about 26,000 hospitalizations and around 420 deaths. Campylobacter, on the other hand, has slightly more infections with about 1.5 million illnesses. And Shiga toxin-producing E. coli has about 265 illnesses with around 3,600 hospitalizations and 30 deaths per year, according to CDC. So next, I'm going to show a tweet, and I'm just going to read the caption. It says, "I just made medium rare chicken strips. They are so good. I can't believe I've never tried it like this before. Can't wait to dig into this with my homemade salad and veggies." Hashtag clean eating is at the bottom, but I would like to update this to say hashtag unsafe eating and also hashtag job security. Bacterial enteric illness comes from a number of sources, including food, water, the environment, and contact with an ill person or animal. We call them enteric illnesses because they do include non-food sources. But what we know about food sources tends to come from outbreak investigations, which tell us that fresh foods are much more likely to be contaminated than processed foods because bacteria are killed by heat. So this is an outbreak epidemic curve where each count on the curve is an outbreak, as reported by CDC. And these are multi-state salmonella outbreaks that were investigated from the year 2006 to 2018. In total, there were 65 outbreaks, which is an average of 5 per year. So here I've actually gone through and made a little pictogram of all of the food items that were the causes of all these different outbreaks. And now I've reorganized them so we can look at them a little more clearly. So you can see that the vast majority of these food items are fresh foods. You can see many of them were fruits and vegetables, especially sprouts, and then things like meat, eggs, and chicken. I did the same thing for E. coli, so there haven't been quite as many E. coli outbreaks per year. The total was only 30 over the same time period, which is an average of about half of what it was for salmonella, about 2.3 per year. But again, you can see that most of the food items are fresh food. And here, for E. coli, it is very distinctly related to leafy greens, sprouts, and typically ground beef or other types of meat. Campylobacter outbreaks are not investigated in the same way that E. coli or salmonella outbreaks are, so we don't know quite as much about them, but CDC did release a report from the National Outbreak Reporting System that looked at 236 CAMPy outbreaks that were reported between 2010 and 2017, and they found that when a food item was identified, the most common culprits were dairy, typically unpasteurized, poultry, which is typically chicken, or it can sometimes include live poultry exposure as well, but not as commonly for CAMPy. And then other fresh foods like mollusks, beef, fish, and fruits. So I asked the same question I asked earlier. Knowing what we know now, which of these foods are healthier? So the next question I wanted to look at in my dissertation was basically thinking about, where do you shop for the food that you eat?
Hi, can y'all hear me? Sorry, I don't know, my phone just dropped out.
Yes, we're
Yeah, I can
actually
hear
hearing
you.
you better
We can
now
hear you.
than before.
Can you hear me or no?
Yes.
Yeah,
Yes.
you can.
Yes.
Okay, great. Okay. So where do you shop for food and how does your neighborhood affect where you shop? Supermarkets and large grocery stores tend to offer a wide variety of fresh food items like produce, meat, poultry, and eggs. They typically have high capacity refrigerators, which is great because it means that the food is kept cold and bacteria cannot grow. Supermarkets are really common in suburban and rural areas, and in the city, they may be more common in affluent areas. Corner convenience and dollar stores, on the other hand, typically will have a smaller selection of fresh food items. They may have very limited produce. They sometimes have eggs. They might have things like deli meat. They might have some fresh fruit. You can see here they have like apples and oranges at this one corner store, but they often have limited refrigeration. And since we know that bacteria can grow at room temperature, this can be problematic. Corner stores are very common in dense urban areas, especially in lower income neighborhoods, and they may contribute to what we call food deserts and food swamps. A food desert is an area in which it is difficult to buy affordable or good quality fresh food. And we tend to think about it where you live really far away from the supermarket, and it's like a vast emptiness between you and the store. But what we're sort of coming to realize is that this is actually not true for very many people. It can be true in rural areas, but in many areas, especially in urban areas, it's more common that people live in what we call a food swamp, which is simply an area where quote unquote unhealthy foods are more readily available than quote unquote healthy foods. So here it's still the same distance to the supermarket, but between you and the supermarket, there's a whole variety of fast food outlets and corner stores where you can buy processed foods that are more readily available. So the main question that I wanted to think about with my dissertation was, if you live in a food desert or a food swamp, are you more likely or less likely to get enteric illness? There's a bit of a paradox here because if you live in a lower income neighborhood and you're shopping primarily at corner stores, if you're really only buying processed shelf-stable items, you're really not that likely to get sick because it's very unlikely that these foods are going to be contaminated with bacteria. But if you are trying to be quote unquote healthy and buying what limited fresh foods are available in the corner store, if it's not stored in the refrigerator properly, then it can make you sick. On the other hand, if you live in a higher income area and you have access to a supermarket, if you're buying fresh foods and they're stored properly in the refrigerator, you may get sick, but it's less likely if it's stored properly. But because there is a dose-response effect with bacteria, the more fresh foods you eat, they can be more likely to be contaminated, and then they can make you sick. So my dissertation looked at the question, are social determinants of health upstream risk factors for bacterial enteric illness? Social determinants of health is a framework where we think about the fact that the conditions in which we live determine how healthy we are. And some factors that we think about are things like social and economic opportunities, as well as neighborhood and community resources. And some of the ones that I looked at here in my dissertation were things like race, ethnicity, educational attainment, poverty, and income, and then also looking at neighborhood resources like living in a rural area or living in a food desert. Social determinants of health are very well-established risk factors for chronic diseases at this point, but they're not typically collected as part of routine public health investigation for enteric diseases. And so they have not been widely studied for this group of diseases. So my general hypothesis for my dissertation was that social determinants of health, like rurality or living in a rural area, race, ethnicity, poverty, educational attainment, and food desert residents would impact where you live, where you're able to shop or eat, and the items that you're able to buy, which would therefore impact your disease exposures to food, water, and animals, and therefore your risk for enteric infection. In order to conduct my dissertation research, I looked at reportable disease data from Pennsylvania. Salmonellosis and campylobacteriosis are both reportable conditions in PA, which means that laboratories and providers are required to report test results to public health authorities. The study population that I used was confirmed and probable cases that were reported during 2011 to 2016 to either the State Health Department, Pennsylvania Department of Health, or the Philadelphia Department of Public Health, which is operated separately from the state. And I did exclude cases that were either linked to a known outbreak or cluster because we knew what made them sick in all likelihood if they were part of a cluster. So I was not so interested in those. I also excluded cases that reported any international travel prior to their illness. And then cases with missing information, like ones that were never interviewed, if they had missing age or sex, or their home address was not geocodable. For data analysis, I first compared food, water, and animal exposures using a chi-squared test, which is a statistical test that compares proportions of an unexposed to an exposed group in two categories. So an example here would be people who ate chicken and didn't eat chicken compared in urban and rural areas. I also use logistic regression, which compares the odds of an exposure in two different categories. So the example here would be something like the increased odds of eating chicken if you lived in a rural area compared with an urban area. And then finally, I looked at comparing disease rates using negative binomial regression, which is a statistical technique that measures the relationship between an exposure and an outcome when that outcome is a count or a rate. So here we would be using this test to compare the average salmonella rates in urban and rural areas, for example. So for my first paper in my dissertation, I asked the question, are Salmonella or Campylobacter exposures or rates different in urban and rural areas? So to measure rurality or living in a rural area, I used a 2010 schema called the Rural Urban Commuting Area Codes, or RUCA codes, which is a census database that's available from USDA that classifies US Census tracts using measures of population density, urbanization, and daily commuting times. They actually have 4 different categories of urbanization, so I collapsed them down into 2. And I said that metropolitan and what they call micropolitan areas were considered urban. And a micropolitan area is basically like a small city, as opposed to a metropolitan area, which would be like Philly, DC, Baltimore, really large areas. And then I combined both small towns and rural areas into rural areas for my study. And if you're interested in learning more, there's more information available from the USDA Economic Research Service, which are the people that publish these data. It appears to be that the last time they updated this data set was 2019, which was still 2010 data when they last updated it in 2019. So here's a map of Pennsylvania, just showing basically where the urban and rural areas are. And just to orient you a little bit, we have Philadelphia in the east, Harrisburg, the state capital, in the center, and then Pittsburgh in the west. And the darker purple census tracts are the rural census tracts, and the lighter purple are the urban ones. So the first thing I looked at was salmonellosis rates by census tract, and I compared urban and rural areas. And so this map shows basically high versus low salmonella rates. The lighter blue is a low salmonella rate, and the darker blue is a high salmonella rate. And then I overlaid where the rural tracts are here with the hash marks over the census tracts. And when I ran the statistical test, I found that in urban areas, the rate was about 8 cases per 100,000 population, compared with the rural rate, which is about 10 cases per 100,000. And this was not statistically significant. So the incidence rate ratio was 1.14, but the p-value was not significant. So this shows us that the salmonella rates were not statistically significantly different in urban and rural areas. But when we looked at Campylobacter, you can see just from this map, similarly, so this time it's green, but the lower rate census tracts are light green and the higher rate census tracts are dark green. And you can see here there is a very clear pattern. And these are all, even though some of these are called urban tracts by the rurality schema that I used, I mean, this is a very rural area here where all these green tracts are, and it's very obviously a geographic pattern, which was confirmed by my statistical testing. So I found that the rate in urban areas was 10 cases of CAMPy per 100,000, whereas in rural areas, it was almost double at 19 cases per 100,000. And this was an incidence rate ratio of 1.75 that tells us that Campylobacter rates were about 75% higher in rural tracts compared to urban tracts. So next I looked at food, water, and animal exposures among case patients and then I dichotomized them by census tract rurality. And so the food exposures that I looked at were having had a restaurant meal prior to your illness, eating any poultry, eating any beef, which would include ground beef or any kind of beef, And then I also looked at combining any meat, poultry, or seafood. So that would include the poultry and beef above. And then I also looked at consuming any eggs, consuming any fresh fruits and vegetables, unpasteurized dairy or juice. And so those were the food exposures I was able to look at. As far as water exposures, I looked at having a household well water system in your house, as well as recreational water exposures, which would be like a swimming pool or going to a beach or a lake. And then I looked also at animal contact, so any animal of just any type. And then I specifically looked at domestic animals like dogs and cats. I also looked at reptiles and amphibians because they are particularly associated with salmonella. And then I also looked at livestock exposures. So we found that urban cases reported more meat, poultry, seafood, and egg exposures compared with rural cases, whereas rural cases were more likely to report eating raw milk or drinking raw milk, having well water, and having animal exposures, which is not all that unexpected. In rural areas, there tends to be a lot more agriculture, which is where we see a lot more exposures to things like animals and also raw milk. And also, I will note, raw milk is fully legal to sell in Pennsylvania for either on-premise farm sales or there's retail sales as well. So that is a little bit different than the landscape here in Delaware. It is very widely available in Pennsylvania. So I also wanted to take a look at similar studies that were done in other states around the country to see how my results compared. So there were not that many studies looking at this type of relationship, but I did find studies in Maryland, Tennessee, and Georgia that found that salmonella rates were higher in rural areas as compared with urban areas. But when I looked at Campylobacter, I found that Campy rates were higher in California, Oregon, Minnesota, Michigan, New York, and Maryland, but they were actually lower in rural areas and higher in urban areas in Arizona and Tennessee, which is very interesting. So for my second paper for my dissertation, I switched gears a little bit and I did a very similar study, but instead of looking at rurality, I looked at food desert residents. So here we were asking, are Salmonella and Campylobacter exposures or rates different in food deserts and in non-food deserts? So to decide which census tracts were considered food deserts, I used the 2010 Food Access Research Atlas, which is published by USDA, which basically presents an overview of food access indicators for census tracts, and it looks at census tracts that are both low income and also where people live very far away from a supermarket. So a tract would be considered a food desert if more than 20% of the people in that census tract live below the federal poverty rate, or they have a median family income of less than 80% of the statewide median income. And then low food access tracts were defined as places where at least 500 people or a third of the population live at least a half a mile away from a supermarket in an urban area or at least 10 miles away in a rural area. And again, here I have the link if you're interested in learning more. It appears again that this was the last time this was updated was in 2019. So this is a map just showing where all the food deserts are located based on this RUCA code in Pennsylvania. And I zoomed in here, interestingly, in Philly and Pittsburgh, you can see that there are many food deserts in both of those cities. So next I looked at disease rates in food deserts and non-food deserts for both Salmonella and Campy. When I looked for Salmonella at food desert residents, I found that cases who resided in a food desert, there were around 8 cases per 100,000 population, as compared with people when they lived not in a food desert, the rate was only 9 per 100,000. So this was not significantly different. The confidence interval crosses 1, which tells us they're not different. When I looked at Campylobacter, again, the rate in food deserts was 8 per 100,000, and the rate in non-food deserts was actually 11 per 100,000, which tells us that the rates were actually lower in food deserts, which was not what I was expecting to see. But Campy rates were about 24% lower in food deserts compared with non-food deserts. I looked at food exposures here for food desert status. I did not look at animals and water because food deserts and foods are more related. But my relationships were similar to what we saw for rurality. So cases who lived in food deserts reported fewer restaurant meals and less exposure to fresh produce and raw milk, but they reported eating more meat, poultry, seafood, and eggs. when compared with people who did not live in food deserts. So what does this all mean? Well, I was trying to interpret my results and looking into studies of microbial food quality in food deserts. And as it turns out, the food quality is quite poor. It's pretty well documented. There was actually a group in Philadelphia that did really good studies going into a bunch of corner stores and actually sampling meat to see how much bacteria they could find on the foods themselves. And they found very high levels in a lot of corner markets in Philly. And they found that typically retail meat and poultry samples are contaminated pretty regardless of location. But they found that in corner stores and other markets that were in lower SES areas, the eggs tended to be more likely to be stored at room temperature. And they also found that produce was more contaminated in the lower SES stores, both of which can contribute to risk. However, paradoxically, when they have done surveys of food handling practices in the home, it has actually been well documented that lower SES populations are actually more likely to report handling food more safely in the home. And this has been attributed to the fact that they may have experience working in the food service industry where they were taught how to handle food safely, and then they carry over those good practices into the home. It's also been hypothesized that higher SES populations have reported riskier food handling and food exposures in the home, which may be contributing to some of this as well. It's also entirely possible that lower disease rates in food deserts are actually related to inequality more than they are to exposure. So if you don't have access to the fresh produce that might make you sick, that actually does lower your risk for bacterial illness. It's also possible that healthcare access can play a role. Only reported cases were included in my study sample. And in order to become a reported case, you have to go to the doctor, and the doctor has to order the test, and the test has to be positive, and then that positive test result has to be reported to the health department. So if any of those things in that sort of pathway don't happen, we will never get your test result. And it's entirely possible that healthcare access can differ either by SES or by food desert residents, which could be contributing to these results. So a few strengths of my study. This was the first that I know of, the first population-based study to look at multiple social determinants, as well as food, water, and animal exposures. And we had a large sample size, and we were able to harmonize data from the State Health Department, Pennsylvania Department of Health, as well as the City Health Department in Philly, which do maintain two separate databases. Pennsylvania has a very large rural population, which makes it perfect for this type of research. And actually, we had relatively high poverty in both urban and rural areas, which also made it a great place to do this type of research. There are a few important limitations to keep in mind when interpreting these results, however. These were passive surveillance data. And so, like I said, in order for cases to be reported to the health department, the provider has to order the test, and then the result has to be reported to us. And so it's entirely possible that there are underreporting of these results, possibly differentially by SES. It's also possible that because statewide, the case patient interviews that were used to collect all the information that I used were done by a ton of different jurisdictions and investigators, and so exposures may have been collected differently depending on who the interviewer was. I also only included sporadic domestically acquired cases, meaning that they were not associated with an outbreak. And it's possible that the cases that I excluded as part of the study are different from the ones that I did include. And it's also possible that the cases that I excluded because of missing data are different than the ones that I did include. So those could also impact the results. Finally, food, water, and animal exposures were all by self-report. So it is routine for when a positive test result comes into the health department, an investigator from the health department will attempt to call the person and ask them basically, what were you up to in the week or so before you got sick? However, by the time we get to this interview, it has often been like 6 to 8 weeks, since they were actually ill. And so there is a lot of recall bias in these findings. We do know that people tend to forget what they did. They forget what foods they had, they ate. So that can also impact our results. And because of the sample size and missing data issues, I also had to categorize both the knows and the unknowns together in order to keep more cases in my sample size. But that may decrease the specificity somewhat for the test results or for the study results. I also have, it's very difficult to determine what is the exposure, baseline exposure for the underlying population at risk. So, you know, I could say that in my study, X percentage of people drank raw milk, but we don't have good estimates in Pennsylvania of just generally of the population, how many people on a given day might be drinking raw milk. So it's a little bit hard to interpret because it's hard to know what that baseline is. However, in conclusion, enteric disease control programs should be tailored for communities. So that was my main takeaway from my dissertation. My recommendation was that in urban areas or in food deserts, we should really focus on reducing food contamination and also structural barriers to fresh foods. In rural areas and non-food deserts, it's really important to try to reduce raw milk exposure and mitigate exposure to water, especially well water and animals. Access to fresh foods is absolutely critical for health equity, but it is important to remember that these foods are risky. And so when we have programs to bring fresh foods to communities of need, we need to mitigate these increased risks with things like using our government authority to conduct inspections and make sure that they are refrigerating foods at the proper temperature. We should also include food safety education for proprietors that are selling the foods as well as consumers that are buying the foods, especially if you're introducing foods into a new area where people don't really have exposure to them a lot. It's important to make sure that people know how to handle those foods safely. So I also, because of my results looking specifically at urban versus rural, I wanted to look also at cities across the US. So I did a little sort of sub-study looking at social determinants. And here I was looking at Salmonella and E. coli, so it was a little bit different than Campylobacter, but I was looking at Salmonella and E. coli in cities. And for this, I used a data set called the Big Cities Health Inventory, which is a project of the NACHO, which is the National Association of County and City Health Officials. And this is a publicly available data set, and they have lots of information on different health indicators. And uniquely, they include both social determinants and enteric illness data, which I was not able to find in many other public use data sets. There are member cities that participate in the Big Cities Health Inventory, and the ones that I included were from the top 30 urban areas as defined by the Census Bureau. And these urban areas have to have both a population of at least 400,000 and a locally controlled health department. And so of the 30 cities that participate in the Big Cities Health Inventory, I included 20 of them in the study because they didn't have any missing data. So when I looked specifically at are social determinants of health associated with enteric illness in cities, the answer appears to be yes. So I found that Western cities tended to have higher rates of disease, whereas there were lower rates of disease in cities with larger communities of color, with higher rates of poverty and higher rates of unemployment. I want to make sure and acknowledge all of my collaborators on this project. I had 2 co-advisors on my dissertation, as well as my dissertation committee, and I had collaborators from the Pennsylvania Department of Health, as well as the Philadelphia Department of Public Health and Drexel University that were really instrumental in helping me get this work done. And with that, I'd like to thank you for listening, and I'd be more than happy to take any questions that you have. Thank you.
Wonderful. That was excellent, Dr. Smith. Thank you. So questions for Dr. Smith. This is extremely interesting. I have a few questions, but I'll let others go.
Oh, I don't think we can. I can't hear you, Aoi.
Can't hear me? Oh dear. Is this better?
I can hear you.
We can hear you. Mhm.
Okay.
No.
Huh. Lynn, you talk and let's see if she hears you.
Can you hear me, Dr. Smith?
Oh. Maybe now I can hear you. Can you talk?
Hello?
Oh, hi. Sorry.
Okay, good. I said that was very interesting.
Oh, thank you.
Yes, like some of that stuff I would have never thought about. And I was busy writing down all those resources that you mentioned. So I'm going to look them up later. But questions for Dr. Smith? And while you guys think, unless someone is raising their hand that I can't see, I will ask my first question. The information is surprising, and I think a little bit saddening, right? No one wants to get enteric illness.
Yes.
But in a way, the disparity is kind of upside down because the people who are poorer are not getting the illness, which we don't
Right.
want them to be sick, but it's sad to think that they're not getting sick because they're not eating the fresh foods. But
Yeah.
anyway, my question was about that slide where you showed where the lower socioeconomic groups handled food better at home.
Yeah.
I thought that was intriguing, and maybe it is because, you know, maybe they've worked at McDonald's or whatever. But do you know, and this might be a crazy thought, but do you know if it is that they are more risk averse, right? Like, if I have good health insurance, then I'll eat the raw poultry like you saw. But if I know that if I get sick, it's going
Yeah.
to break my finances, then I'm like, no, I will cook that chicken. Do you know if there's any of that in that?
Yeah, I suppose that's possible. So this particular study that I cited, they did say that it was because they attributed it to food service industry work and having been trained on the job to handle food safely. But I think absolutely it could be a risk aversion thing. I mean, especially because a lot of this work was done or the study time period included a lot of the years before the ACA was in effect, and the unemployment rates or the uninsured rates were much higher than they are today. So I think absolutely it could be a risk aversion issue too. I don't want to downplay the fact that it could also be a healthcare access issue. So people could have the same rates of illness, but they just aren't reported to us because they never could get a test because they couldn't afford to go to the doctor or they couldn't afford the lab test or whatever.
Thank you.
Mhm.
Other questions? This must have gotten your wheels turning. I mean, so I guess the other question for Delaware, which I guess Delaware varies between, based on your description, rural and what was the thing? Not metropolitan. What was the other thing?
Micropolitan, yeah.
Metropolitan. I always tell people Wilmington is not a city, but anyway.
Yeah.
um,
Yeah, I'm not even actually, truth be told, I'm not sure if Delaware would count. I don't even know if Wilmington would count as a large city for that definition. It might be a small city only. I don't know. I would have to look it up and see what they think about it in the data set.
Yeah, but what would be your recommendation? So with this information now, and you as being like, yeah, I know that now you're the state epidemiologist, but I can see that your heart is with the enteric diseases. How do we think of health disparities? Again, this has my mind all mixed up because we're used to disease being more with people who are kind of like disadvantaged, but this is kind of the opposite. So
Yeah.
any words of wisdom, take home points?
Yeah, I mean, I think there's a lot of messaging out there saying like eat fresh foods to reduce chronic illness, right? And I think that's a great message and it's not untrue, but I think also just pairing that with a message of, oh, hey, by the way, you got to refrigerate it properly or you need to cook it thoroughly or, you know, whatever safe handling practices need to be in place for whatever that food is. I think it's just really important because I think you know, and if we're having, for instance, like farmers markets are great, but there's no refrigeration at farmers markets, right? So like, how do we make sure that we're not introducing additional time and temperature abuse to, you know, if we're bringing like a farmers market to a community of need or something like that, you know, or if we have a corner store, do they have proper coolers in the corner store? Do we need them to upgrade their coolers before they're able to bring in that fresh food so that they can not poison people when they sell them the food in the store? So I think it's just sort of pairing the message of like, hey, eat these foods to reduce your risk for chronic illness, but also reduce your risk for enteric illness as well.
Great, thank you. Other people? All right, if no other questions, going. This was great. I mean, that it was just also unexpected for me. I did not expect that information. So I guess other people are still trying to process it.
Yeah.
I would
where's
just like
Dr.
to
Kushner?
say a comment. I mean, I'm listening. It's an excellent presentation. It really is,
Thank
and
you.
it makes you really think. And you're absolutely right. It kind of is a little bit of a paradox there. I just wanted to comment. I said it's an excellent presentation, very enlightening. I will make sure I choose where I'm choosing my foods. I make sure they're well refrigerated. So strong work, good points. I like it a lot.
Yeah,
So.
thank you. Yeah,
Thank you.
unfortunately, working in foodborne epi for as long as I have, I mean, nothing is really safe. People are like, oh, what foods do you eat or not eat, you know? And there's a short list of foods that I just don't care much for, but proper food handling, keeping things cold or hot, you know, really can go a long way to reducing your risk, and washing your hands. That's one of the biggest, but we know that for everything, right? Keeping hand hygiene is important for tons of stuff, not just for foodborne illness.
Well, I've got to take this message home to Mrs. Kushner because she loves to go to the farmers markets and things. I'm like, oh, you know, oh, you know.
Yeah, but like, you know, go first thing in the morning. Don't go at 2 o'clock in the afternoon when stuff has been sitting out all day long, you know. So there's ways to reduce your risk.
Washing our hands.
And it's really important to support agriculture and farmers and stuff. I'm not saying people shouldn't shop there, but you know, just try to reduce the risk as best we can.
Thank you, Dr. Erica.
All right, anyone else? Well, if not, join me in thanking Dr. Smith for presenting this wonderful presentation to us this evening, and we'll see you next month. Thanks, Dr. Smith.
Yeah, you're welcome.
Thank
Have a
you,
good night,
Dr.
everyone.
Smith.
Good night.
Thank you, Dr. Alvey. Thank you, Dr. Kushner. Have a good night. This will be recorded, or this has been recorded. We'll post.
Wonderful.
Thank you.
Thank you.
Take care.